Welcome everybody to ACON's Community Forum on Monkeypox. For those of you who don't know me, my name's Matthew Vaughan. I'm the Director of HIV and Sexual Health at ACON. My pronouns are he, him. I'm joined tonight by an incredible panel of health experts who I'll introduce in a few minutes. But before we start tonight's proceedings, I'd like to begin with an acknowledgement to the traditional owners of the lands on which we're meeting on. I'm joining you today from the land of the Bidjigal people, and I pay my respects to elders past, present, and emerging, and I extend my respects and a warm welcome to any Aboriginal and Torres Strait Islander people who are joining us today. If I can also acknowledge that sovereignty was never ceded, and this always was and always will be Aboriginal land. Globally, there have been more than 40,000 reported cases of MPOX. In Australia, we've seen about 89 confirmed cases, of which a number are in New South Wales. It's important to state from the very beginning of tonight's forum that while anybody can get MPOX, the vast majority of cases have been among gay and bisexual men and other men who have sex with men, as well as trans and non-binary people who are also having sex with MSM. I'm cognizant of the stigma and discrimination that can come by naming populations, particularly in the media and public discourse. However, I also think it's important that by not naming these groups, we are limiting our public health response and the need to get messages to those most affected communities. It's also important that I point out that we're in a rapidly changing environment. Tonight, we're going to give you the most accurate information as we have it today. However, those messages might be updated as we learn more. It's important that we all remain vigilant to public health messaging and that we will continue to keep you updated as we learn more. A few housekeeping things. So just a little reminder to be respectful in the chat as much as possible. We love a vigorous conversation, particularly in the chat window. So please do feel free to use that. And also remember that this session is being recorded. If you have any questions, please do use the Q&A feature. There's lots of friendly ACON staff people there that are to respond to your questions, and we'll aim to get as many of those in tonight's forum as possible. If you're viewing on Facebook, feel free to get in touch with our page admins who can come back to you when the session's over. I would now like to introduce you to our wonderful panel of health experts this evening. Our first panelist tonight is Dr. Valerie Depeche. Dr. Valerie, pronouns she, her, is a medical epidemiologist based at New South Wales Ministry of Health, where she heads up the Communicable Diseases branch. Having recently moved from the United Kingdom, Valerie's previously held senior roles within the UK Public Service within Public Health England. She now leads a team of scientists, data managers to monitor the HIV epidemic and the quality of care for people living with HIV. Dr. Vincent Cornelius, he, him, is a specialist in sexual health medicine and addiction medicine. He's dual qualified, among other things. A manager of the medical unit at Kirkton Road Centre, or KRC as it's known, in King's Cross. Dr. Vincent is the chairperson of the National HIV Advisory Group for the Australasian Society for HIV, Viral Hepatitis and Sexual Health. He sits on the executive committee of the chapter of Sexual Health Medicine at the Royal Australian College of Physicians. Welcome, Vincent. Welcome, Valerie. And also Timothy Walk. Timothy Walk has over 7 years experience delivering HIV and sexual health and LGBTQ health and peer education programs and services in New South Wales. As ACON's manager of community partnerships and population programs, he works across a diverse range of community health programs and community populations. So tonight we're going to cover a broad range of topics, and as I said, to give you the latest information that we have. I thought we'd start with just a little bit of an overview, and Dr. Vincent, I'm going to come to you. If you could tell us a little bit, what is monkeypox or MPOX?
Thanks, Matt. So Mpox is an orthopox virus, which means it's related to smallpox and cowpox. And of course, smallpox was eradicated many years ago thanks to a vaccination program. So it being a viral infection, it does cause a general body infection. So people can present with fevers, muscle aches, joint pains, headache. And importantly, what is quite common with Mpox infection is that people get really large swollen lymph nodes that are quite painful. Commonly, we see them in the groin, as we are also seeing lesions, so Mpox lesions in the groin. And I guess what distinguishes the presentation of Mpox from other viral infections is that we're commonly seeing people with skin lesions, so typical skin lesions or pox-like lesions. And we're commonly seeing that in the genital area or the anal area, so both the area around the anus as well as inside the anal canal and in and around the mouth. So I think that's probably Mpox in a nutshell.
Yeah. Could you tell us a little bit about how it's transmitted, realizing that we'll go into some of this later on, but just an overview?
Yeah, look, it's a really important question, and it's one that's been a point of a lot of discussion and contention in the sort of experts that have been responding to this. Initially, the messaging that was coming out was that, this is transmitted by close contact and respiratory droplets. I think we've now seen a few studies that have looked at this in detail, and I think we can say with some confidence that Mpox does in this current outbreak, as opposed to previous outbreaks, in this current outbreak, it appears to be sexually transmitted. As you said correctly, it's largely been seen, and the vast majority of cases have been seen amongst gay, bisexual, and other men who have sex with men. And we've not seen much spread at all beyond that community. So, and as I said, we're mainly seeing lesions in the bodily parts that are used for sex, so mouth, genitals, anus. And I think given all of that, and given what we've seen in terms of isolating virus from, say, semen and other bodily fluids, I think we can be pretty confident now that this is a sexually transmitted infection, or at least that in the current outbreak, it is behaving as a sexually transmitted infection.
That's really good to know. So, like, what are some of the symptoms that people would be seeing to, that they might want to come forward if they've noticed any of them?
Yeah, and again, this gets a little bit difficult, but I think to put it in a nutshell, if so some of the sort of general viral symptoms can be hard to distinguish from other viral infections, so that makes it a bit difficult for people to come forward early. Like I said, the distinguishing feature of these general viral symptoms are these large, painful, swollen lymph nodes, as well as sort of muscle aches, back pain, joint aches. The more specific symptoms that we've seen are these pox lesions on the skin. So these are lesions, as I said, in the genital area, anal area, and mouth most commonly. But they again can present in a few different ways. So they can just be sort of these red dots through to blisters, through to pustules. So pustule is a blister filled with pus, right through to sort of these ulcerated sores. And they then form scabs, and then eventually the scabs fall off. So for anyone, my general advice would be, if you see any of these lesions on your skin, particularly if they're anal or genital or around your mouth, but they can occur on other parts of the body. If you're all of a sudden seeing these lesions on your skin, and that may be a single lesion or multiple lesions, my strong advice would be to go and seek an opinion from a medical professional, preferably a sexual health physician in your local sexual health clinic. But do phone ahead to the clinic and say, hey, I'm worried I might have Mpox. I need to come in and see you guys.
We're going to touch on that a little bit later, but will everybody have symptoms?
Yeah, look, it is thought that asymptomatic carriage of Mpox is really uncommon. There's some early work that's been looking at this. There's a study in Belgium where they just tested all swabs collected at sexual health clinics, and they tested just all of them for Mpox to see if they might have missed some cases. And they found that perhaps they've missed 1% of cases, so really uncommon. Very different from what we see with, say, chlamydia, gonorrhea, or syphilis, where the majority of cases, where asymptomatic carriage is much more likely. So I think we can be fairly confident, at least again at this point. And thank you for making that point earlier, Matt, that, you know, everything I'm saying tonight is based on our current knowledge. Things can change, but certainly currently it looks like asymptomatic carriage, so people having Mpox without having any symptoms, is really unlikely.
Okay, that's really good. So let's look at the current context now. And like, Australia is not isolated, but Valerie, I wonder if I can come to you and kind of, if you could give us a little bit of an overview into terms of what's happening globally with Mpox.
Hi, hi everyone, and thanks so much for organising this and the opportunity to share. And as we've said, this is such a moving and very quickly changing situation. Certainly globally, as you've said, Matt, there's over 40,000 in this current outbreak. And just to remind people that this actually began first, was seen more in Central and Central and Western Africa, and related to travel and isolated cases, whereas in this latest outbreak, we're seeing it much more within the gay, bisexual, men have sex with men community as such. So it is up to 40,000 cases, of which 10,000 alone in the US, up to 3,000 in the UK and places like Germany and in Spain, up to 5,000 cases. So it's going rapidly. What we do know, though, is that rate of change is starting to slow down. And that's partly because there has been the introduction of vaccine, which we'll come back to. So the situation in Australia is more favourable. We were able to, you know, very early on, try and take as much experience that we were seeing from other countries in terms of what we were seeing. And certainly, at the moment, predominantly from the almost 90 cases we have across Australia, the large majority are people who've returned from acquisition, probably abroad. So we do, though, have local transmission occurring. Much more has been reported now in Victoria, predominantly in Melbourne. And as you would have heard, many of you or not, we now have, from this weekend, also reported our first local transmission reports within New South Wales. So that's potentially changing also the situation and our key messaging. So certainly, at the moment, it is still only a very few people. We're not saying that most people are at risk of monkeypox, although anyone can get monkeypox. And so getting the message out around the symptoms, as Vincent has described, is really, really key and important. So that's the situation at the moment in a nutshell.
Thanks, Valerie. So, I mean, the situation is obviously very different here in Australia. We're seeing much fewer cases at this point. So what's been New South Wales' primary response to date? And yeah.
Yeah, so I think most people will have a much greater sense of how we control infectious diseases after or living through COVID. Before that, public health was a bit of a, what do you do when I used to talk about my job? But essentially, as you'd be aware, we really need to understand very quickly what is a case definitions, and understanding who's possibly at risk. So what is a contact, and understanding the transmission. And as Vincent said, we've been learning a lot around that. So initially, from the little understanding we had, and we can't emphasize the lack of data that we've had around monkeypox, internationally. We didn't know whether or not it was largely respiratory or it was going to be a largely close contact, but certainly now an understanding from the experience of overseas that this is a very, very much a close contact and mostly sexual contact. So the route around airborne transmission is something that at the beginning we were worried about, in which case, definitions and contacts and follow-up of contacts and giving advice around this airborne would be, maybe closely like a COVID type transmission. We know that's not the case at all. We're talking about something very, very different here. So initially, you have to have really, in public health, a lot of discussions with other colleagues across jurisdictions to discuss what is going to be your control guidelines in terms of cases and contacts. So that's one area. Of course, we've had very, very early on, very close discussions with our partners, with our clinical partners, with our community partners around getting the message out, increasing the awareness. No clinician had come across monkeypox in this country, or very, very few. So understanding what those symptoms would be like, and also our laboratory capacity. So there's been, you know, a lot of activity. And then, of course, more recently, it's been about trying to get the vaccine into the country, which, of course, is an extremely rare commodity around the globe at the moment, and trying to prioritize that vaccine and get it out as soon as possible.
So we're definitely going to talk about vaccines tonight. Obviously, it's going to be a big feature of the conversation. But I suppose just in a really brief nutshell, what are the vaccination options here in New South Wales?
So just to say, the vaccines for Mpox are actually smallpox vaccines, but they are known to be, as best as we know, again, data are a little bit lacking in terms of real randomized control trials, if you like, in this area. But we know that when smallpox vaccine was introduced many years ago, it also eradicated essentially monkeypox. So we know it is efficient. And essentially, we know that we've now seen monkeypox again because people have waned immunity and are no longer vaccinated for smallpox. That is probably why we've seen a resurgence of monkeypox. So the vaccines have had a number of generations, and the two vaccines that people may have heard of that we've had in Australia, one is called ACON 2000. That is a second generation monkeypox vaccine that has quite a few unpleasant side effects and some serious ones. So we certainly did not want to be rolling out this as a main vaccine. But more recently, in the last few weeks, we've actually been able to secure some doses of the Genius vaccine, which is a third generation vaccine, and that has a much better profile in terms of contraindication and side effects. And that is now the vaccine that is being used mostly worldwide to vaccinate against small monkeypox.
Okay, that's good to know. And I do want to definitely come back to this and answer some questions that we've had that have particularly come in about the vaccine. So I suppose as we've said, Mpox has been coming through or affecting communities of men who have sex with men, Europe and the USA, and now with a few cases of local community transmission here in Australia. Valerie, what would be some of the reasons that we're starting to see this?
Well, I think it was inevitable that we would be seeing local transmission, and there's a few reasons for that. Essentially, it is going to be, as we've said, it's transmitted through close, very close skin-to-skin contact or sexual contact. One of the issues is that people may not be aware of their own symptoms, or they may have very mild illness. And as Vincent, explained, some of the lesions are very, very much around the perianal or genital area, and people may not be aware as well. So you can have transmission, and this has been the case in some of the Victorian cases with the local transmission, where people didn't think they were symptomatic and turned out to be symptomatic. So it is really, really important that I think we'll come back to messaging. But if you've just come back from overseas and you've been attending, lots of parties or had casual partners of any kind, I think it's really important that you get checked out. You may not know that you have symptoms, and it's not just monkeypox that you want to clear out. You want to actually have a good, bill of health. So that's one of the issues. Asymptomatic, so not having symptoms, may become more important as we go along. That could be the way to actually pass on, although, luckily it's largely rare. So if most people who are aware of symptoms are getting checked out, and during that time are isolating and certainly not having sexual partners during those very, time where they may be very infectious, that's how we're going to prevent onward transmission, as well as, of course, making sure people have vaccine.
Okay, great. And Vincent, I want coming to you. So why is this particularly sticking or affecting gay and bisexual men and queer men and other men who have sex with men? Is there anything specific, or it really is a case of?
Well, no, I don't. As I think Valerie pointed out earlier, that, in principle, anyone can get MPOX. I don't think there's anything specific to gay, bisexual, or other men who have sex with men that make people more susceptible to MPOX. I think it has been a bit of a case of a perfect storm in a way. I think what as Valerie pointed out, a lot of people now are not vaccinated against smallpox. So Australia stopped vaccinating against smallpox in 1980. So anyone who grew up in sort of the end of the 70s or early 80s or beyond is unlikely to have received a smallpox vaccine. And those are the vaccines we're now using to protect people against monkeypox. So we have a population that is more susceptible to monkeypox than it would have been a couple of decades ago. And I think the other sort of predisposing factor, perhaps on a population level, is that, we've just come out of 2 years of essentially COVID lockdowns and people restricting their activities. And now I think it's fair to say, but please, people correct me if I'm wrong, but I think it's fair to say that everyone's fed up with being at home. And now we're finally coming out of this sort of restricted lifestyle, and people just want to be able to go out and enjoy themselves. And we just went through Pride season in the Northern Hemisphere. So, there was lots of Pride events. People were, clearly, hopefully having a good time. And in the midst of that, we've seen the introduction of monkeypox into a community that is affectionate. And unfortunately, that means that it can spread between people. So I think it's been a bit of a sort of perfect storm in that way.
And I think before we were sort of hesitant, or not, we didn't know about it being sexually transmitted, but what we were talking about was passing through sexual networks and that, close contact and very definitions of sex. I do want to touch on, but a particular area, because obviously next year we're coming into World Pride, and there's already been a question that's come through on the community questions tonight. Valerie, what's the plan for ensuring that the government has plenty of supply of vaccine ahead of World Pride?
I think it's daily phone calls to the company. So it's not that people are not trying. The demand, there is only one company in the world at the moment manufacturing this vaccine. As you can appreciate, we're putting our demands, as well as many others. I think, there are hopefully other companies that will start to manufacture this vaccine as soon as possible. But in the interim, we're really sort of basically on a waiting list for vaccines. We have secured more vaccines late September, early October. We don't know exactly how many that is for the state, but, we're doing all we can to secure as much vaccine as possible. So, to reassure, it's not that people are not trying, it really is that there is a global demand that is, far exceeding the supply at the moment. So that's what is going on. There are obviously people who've been vaccinated abroad as well. And what's important to know about the vaccine is that there's still a lot we don't know about the response, and it is not 100%, even with 2 doses. So that the course of ideally is at least 2 doses of the vaccine a month apart, maybe even 2 or 3 months apart, maybe some further month apart. But as we've explained, a lot of data on this is still lacking. We have the experience of already thousands of people receiving vaccines abroad, and we know that their safety profile is extremely good, and we know that that probably is helping in terms of reducing the monkeypox situation in some of those countries. So it is working at a population level as well as a personal level, but it's important to know that it's never going to be 100% for everybody.
Valerie, there's been another particular question coming through around, is New South Wales considering a dose sparing approach? And this might be something that we can come back to later on, but I'm just aware there are a couple of questions coming from the community panel. And one of them that is particularly coming out is around airborne. Is monkeypox airborne, Vincent? So I'm wondering if you could elaborate a little bit more on transmission routes.
I'm very happy to elaborate. I think, and again, this has been the topic of much discussion. I think we can now confidently say that monkeypox or Mpox is not airborne in the general sense of airborne, as Valerie pointed out as well, in terms of what we see with COVID. The transmission is very different. And I think perhaps to kind of illustrate this, so as we've talked about, the majority of cases that we've seen in Australia have been what we call imported. So they're people who've acquired Mpox overseas and then have gotten on a very long flight to Australia. And despite being on a plane with lots of people and sharing a toilet with lots of people over a long period of time, we have not seen transmission of Mpox to anyone else on those planes. So it's not like we're worried that people who've contracted Mpox will then pass that on to people with whom they don't have close contact. What we're concerned about in terms of transmission is very close contact, particularly sexual contact. And so the advice that we're currently giving people, Valerie will probably want to add to this as well, but the advice that's being given to people when they are getting diagnosed is if you have any lesions, make sure they're covered so that you don't potentially expose other people to the lesions, because the lesions on the skin, the Mpox lesions, contain virus, and that can be transmitted to others through direct contact. Of course, the other advice is to not have sexual contact with any sexual contact while you have Mpox, so while you are symptomatic, because if you have lesions, for example, in your anal canal or in your mouth or in the genitals, again, they're all sources for potential transmission to others. And beyond that, and this is really quite, I think, tricky to deal with for people who have been diagnosed with Mpox. There's some evidence that if you have Mpox, it's considered that you may be able to transmit Mpox right up until the point where the scabs have fallen off the lesions and the skin has completely healed. So you've got completely new, fresh skin. But beyond that, the virus may stay in your semen for a further 8 to 12 weeks. So it's really important that that's taken into consideration as well. Some jurisdictions advise that people continue using condoms for any scenario where they may expose their semen to someone else, or they may expose someone else to their semen. So any penetrative sex, but that would also then include oral sex. So using condoms to avoid exposing people to your semen for another 8 to 12 weeks after you've recovered. And then there's varying advice on what people should do in terms of isolation while they're sick. So of course, not having sex is clear advice, but perhaps Valerie can comment on the other isolation advice that's currently being provided to people around whether they need to stay at home or whether they can go to work.
We'll come back to that particular advice around isolation. But Tim, I want to bring you into this conversation. Like, I think monkeypox, Mpox is really coming off the back of COVID, and many people in our communities also have a lived experience of early days of HIV. What does this mean for monkeypox, and how does that affect people's attitudes and also, their behavior towards monkeypox?
Yeah, thanks, Matt. So I think one of the things that really stood out to me that Vincent said is that our community is very affectionate. But I would also build on that and say our community is also very caring. And what I mean by that is, if we look at the history of HIV and we look at our COVID response as a community, we've actually demonstrated that we can adapt as a community and change our sexual behavior. And that was really around not just protecting ourselves, but also protecting all of us as a community. So I actually think for our community, we're resilient and we do care about each other. And time again, we've actually shown that we can do this. And I think, yes, it's unfortunate that this has happened now, but on the flip side, we're not in North America during Pride season. We're in, like in my case, Sydney with 12-degree days, and we have time to actually prepare for our Pride season next year. So I actually think there's a few, unlike say North America, which might have been a perfect storm around that, for us, we're in a better position. That would, yeah.
So we're talking about Pride coming up. What do we know in terms of, Valerie or Vincent, a question for either of you, in terms of attending dance parties or events at the moment? Is there any evidence around transmission at events like this, or is it something we should be concerned about at this point?
I'm happy to jump in. So I think, but Valerie, you're certainly welcome to add. Certainly that was one of the situations we were concerned about, because again, there's so much that was unknown about this right at the start of this outbreak. And again, just remind people, and I'm sure everyone's aware, but we've really been talking about something that's only been happening for the last 3 months or so. Like, this is all very fresh. Something we were concerned about is, what is the potential risk of transmission during dance events when people may not be wearing a lot of clothes, people might be quite sweaty, might be rubbing up against each other. And I think there's reason for the sort of health sector to be concerned about that. But we haven't seen mass transmission in those scenarios. So there's been a ton of dance events in the Northern Hemisphere over the past Pride season, and we haven't, again, seen this sort of mass transmission. Particularly, we haven't seen any significant levels of transmission beyond gay, bisexual, and other men who have sex with men. And I'm sure there were lots of other people at these dance events, other members of the LGBTIQ community particularly, who weren't affected by MPOX transmission. So I think we can, I would hesitate to say that we can forget about that, but I think we can, relax a little bit about the possibility of transmission during dance events.
Okay. Valerie, anything to add on that?
Yeah, I would hate to cut the fun. So certainly, I think definitely go ahead. I think it comes back to your point, Vincent, which is, if you've got obvious lesions, you cover them up. If you were at the stage where you had lots of lesions, I don't think you'd want to go out dancing with all your clothes off during that time. It'd probably be best to stay at home. So, if you're symptomatic and you have lesions, that's the time that you're most infectious. And certainly, wherever they may be, if they're exposed in areas that, might result in very close contact with others, I think it would be really, important to reduce taking off all your clothes at that point. If it's right across your chest, for instance, probably not a good look either at a dance party, I assume. But the issue is, Vince is completely right. We would have seen a lot more cases. If it had been airborne, it would have been like COVID. We would have known about it from, a wide range of scenarios. And as you said, we've not had a single case. And I guess Australia's unique in our very long haul flights. There hasn't been any contacts that have acquired it this way. And certainly, dance parties are really a site where lots of people go from various sexualities and others, and yet it's still very much a focus on sexual transmission, I think, that we're worried about.
Sorry, just to add, Valerie, I wasn't suggesting that people go to a dance party when they have MPOX. But,
I know. I was just throwing it in there.
Yeah, because I suspect people perhaps wouldn't feel like going to a dance party anyway when they're unwell, and that wouldn't be advisable. But I guess the point I was trying to make was that I don't think we need to be cancelling dance events, or I don't think people need to not attend dance events when they're well for the fear of contracting MPOX.
And I think you're quite right. We're also, we've been lucky that we are in winter through the most important time of COVID transmission abroad, and more people will have vaccine now. Coming back to your point, and am I jumping a question? I don't know. We're hoping to secure more vaccine. We're also looking at ways of making that vaccine be, vaccinate the most number of people, and that's looking at different modalities. So at the moment, subcutaneous is how you provide just under the skin. If you did it intradermal, which would be more like a BCG on just, on the skin there, you might be able to spare doses, and that would make the vaccine, be able to give that to many more, 5 times more. So, but it's things that we need to learn. It's still experimental in some ways, so we need to be really doing that in a way that we make sure that people are safe and aware of, what we're doing. But we'll be in a much better place when we get to that Pride event next year, with many also of our overseas travellers also vaccinated, I assume. Certainly that would be a message to put out for Pride events, etc. So hopefully we're in a much better situation than being caught unawares as many countries were in the summer in the Northern Hemisphere.
Thanks, Valerie. So we're getting a lot of questions coming through on the Q&A section, and I do want to come to some of those, but I know that some of them are going to be covered off in our in later parts of our conversation. Valerie, you've kind of talked about how we've had an initial rollout of the vaccine, and I want to touch on that because there's some questions that came in through the registration form on people accessing the vaccine. But outside of the vaccine, what are New South Wales or recommendations from New South Wales Health around protecting ourselves against monkeypox?
So firstly, I think it's really important that if you are symptomatic, you're covering those areas. And until now, as Vincent said, that we've been asking people to isolate as much as possible. That advice is actually going to be reduced a little bit more from the jurisdictions coming together and looking at the most available data, showing that actually, even if you are symptomatic, but you don't have any exposed areas, then you don't pose a risk. So the issue of isolation is going to be reduced. Obviously, if you can work from home, you should and could and remain isolated, but it's not, we're not talking about our COVID days. And I take Tim's point. I think we've all suffered many times with quarantine. So we want to reduce that to a minimum, and we really don't want people to be unnecessarily staying at home. But certainly protection against monkeypox transmission is when you're symptomatic to be aware of that, to reduce that exposure. In addition, it's really important to get checked out really early, as soon as possible. And we've been very good at that. In New South Wales, most people have really come forward when they've had only 1 or 2, perhaps, lesions, which is fantastic. And that means 2 things. People can really be diagnosed very quickly and know what they have, so they can appropriately isolate, and people who've needed any painkillers or others can be appropriately treated. We've had a couple of hospitalisation for pain, but essentially most people are able to manage at home quite well. But also what's really key is that we're aware and do some contact tracing. Just like with COVID, we're able to, with individuals, pre-warn others, if you like, that they've been exposed to monkeypox, and also for them to be looking out for symptoms and coming forward. So that contact tracing component is still extremely key in reducing onward transmission.
Thanks, Valerie. And I think that was part of the guidance that was coming out from ACON really early on as well, is, by all means, there's been a lot of conversation in the media around, reducing sexual networks, closing down sexual networks. And I think, we're in a very different situation here in New South Wales. And, we have, as Vincent said, we're a very affectionate community. What is really important is what we've seen through a gay men's response through COVID was a lot of responsibility. So a lot of men made a lot of decisions to, close down their sexual networks, keeping it to a small, tight-knit group where they had contact information that they were able to follow up on. And so as we start to progress with monkeypox, some of those, practices may need to be thought of again, but I think a big part is acknowledging the role that contact tracing plays, and having contact information for your different networks is kind of key.
Sorry, Matt.
I'd just very quickly to say, to date, people have been amazing in providing information and really being cooperative and I think the information coming through the community and being able to, seek advice and not feel stigmatized and discriminated against, I think is really, really key. But as I said, people have been amazing today.
Yeah. And I just to add to that, is like, I think the community response has been amazing around the world. And I think part of the reason, as Valerie pointed out earlier, that it looks like in some jurisdictions, so in Europe and the UK particularly, it looks like numbers may have peaked. I say this with a lot of caution because it's early days, but it does look like they may have peaked and they might have started to decline. I suspect if that pattern persists, I suspect that a lot of that is due to the community response. As we've all pointed out, I think the gay male community, gay, bisexual, and other men of sex and men, is a very health-aware community, very caring community, as in people very much, and I think genuinely are concerned about passing infections onto other people. And I think what we've seen overseas in Europe, the UK, and the US is that people have modified their sexual practices in response to this, not just because they're worried about their own well-being, but also because they're worried about transmission to others. And I think, credit where credit's due. I think the community has just been amazing in, again, responding to an infectious disease outbreak.
It really goes to what Tim was saying earlier. Oh, sorry, Tim.
Yeah, just on that though, I also think part of that, and I'll speak to a New South Wales context, is that we're tapping into community practice that already exists. So as gay, bi, queer men, we already collect people's contacts and so on for STIs or for HIV. So it's really just reminding our communities to keep that practice up so that if we do need that to work with New South Wales Health around contact tracing, we can. I just think it's really important that a lot of this stuff isn't new. It's not a new approach. It's actually just tapping into what we already do as a community and really thinking about, well, how do we remind community to do this and to be supportive? The only other thing I would just add here, what was I going to say, is actually, I'll say it later. It's all right.
No worries. Well, if I just finish up with that, I think I am hopeful, and I don't have a crystal ball, but I am hopeful that this is a short to medium term situation, not a long term situation. And I think that is really important. I think for anyone, it's much more palatable to make changes to the way that you live your life in the short term in response to an emerging situation, rather than having to face changing your life around for years. Like, I'm really hopeful that once the vaccine response rolls out, that we can get on top of this, and that hopefully before World Pride comes to Sydney, we've got this sorted, and we can return to some sense of normality.
Thank you. So I want to jump in. By this stage, I should let people know that are joining us for the forum. We do have a bit of a run sheet, but I've pretty much thrown that out the window now because we've got a lot of questions that are coming in. So I'm going to use it more as a guide. But I want to now pivot to vaccines specifically, because we're getting quite a few questions that are coming through, and I'm also cognizant of time. Vincent and Valerie, I wonder if you could just give us a little, let me go back to the question. Vaccines are a key strategy for people to stay protected from monkeypox. Can you tell us what we know about the vaccines in relation to monkeypox? So maybe to you, Dr. Vincent, to begin with.
Sure. Yeah. Look, so most of what we know about the vaccines is the vaccines have obviously been studied in terms of their ability to induce an immune response, as in the ability of the vaccine to create response in the body of the person who's been given the vaccine in terms of producing antibodies. So that's the sort of context in which they were studied before they were given a license to be distributed. Now, as Valerie pointed out, of course, we've never before been able to test these vaccines in terms of their effectiveness to protect monkeypox, Mpox, because we didn't have an Mpox outbreak. So there was no feasible scenario to test that. So currently, there's again, a lot of work looking at what they call breakthrough infections, where, you know, we've in cohorts of people who've been vaccinated overseas, how many Mpox infections do we see in those people who've already been vaccinated? So there's still a lot of data currently being collected around this. The best advice we've got, again, this is extrapolating from antibody studies, is that, you know, after one vaccine, you may have sort of 65% effectiveness, and then after two, it might be 85, maybe a bit more. It is, again, pointing out that it is important that people know that just because you've had the one vaccine doesn't mean it's, you know, you're out of what do you call it? Anyway, it doesn't mean you're fully protected.
Yep.
It does take time for your body to produce a response to that vaccine. And that response peaks after about 4 weeks of the first vaccine. And then ideally, at some point after that, you have a second vaccine to really boost those antibody levels up. And that's when you get the full protection, which might still not be 100%. But if, again, and this is where sort of vaccination theory comes in, that the whole point of vaccinations is to try and vaccinate as many people as possible so that as a group, we have a high level of immunity. And then that means that something like Mpox can't take hold and can't keep transmitting because there's a significant amount of immunity within the group or within the network. Sorry, I don't know if that answered your question, but.
It does give us a little bit. So if I can recap, so what you've said is that the vaccine that's available is giving, after one injection, is giving about 65% protection, and that the best response would be receiving a second dose after a period of time that will give us a higher rate of protection, but still not 100%, and that it is still possible to...
Yeah, and again, just to point out that I'm sorry, I don't want to repeat myself, but I think it's important to know that this is based on antibody studies rather than on clinical effectiveness, because we just haven't been able to study it clinically yet. But that work is currently ongoing. And
so how long will that vaccination last for? Like with COVID, we've seen that we need to get kind of boosters every 3 to 6 months. Is that something that's going to be likely the case for monkeypox as well?
No, so monkeypox virus is a very different virus from coronavirus in many different ways. So COVID is an RNA virus. For those of you who are scientifically minded, MPXV or Mpox is a DNA virus, which has implications in terms of it's less likely to mutate as rapidly as COVID is. So the virus itself is unlikely to change as quickly as we've seen with COVID. And that is important, of course, in terms of how we try and vaccinate against it. The other thing to keep in mind is that, as we've talked about, that the vaccines were originally used to protect against smallpox. And what they found was that they induced very long-term protection. So once you're immunized, you're likely to be protected for years, if not a lifetime, unless you develop a condition that affects your immune system. So it's not likely that we'll have a scenario where people will need to keep getting re-immunized or reboosted every year or every 2 years. Like once you've had your 2 doses, you should be good.
Right. Can I ask a particular question? So for members of the forum tonight that are here from our trans community, do we know if there's any interactions or anything we need to be cognizant of if you're taking hormones or tea and the vaccination?
Yeah, very good question. There's no problem. So, and I would like to highlight as well that certainly trans and gender diverse and non-binary people are also eligible for vaccination. So really the criteria for vaccination, and we're in a tricky situation with limited supply, but the criteria for vaccination are really, are you a person who has sex with men who have sex with men? And if you are a person who has sex with men who have sex with men, and you think you might be at risk due to your sexual activity, then you should I think, consider getting vaccinated. Currently, that's difficult because there's no supply available for many people. But going forward, when more supply becomes available, I think that's really important.
And we're definitely going to kind of touch on that eligibility. But so I just want to check, there's no interactions necessarily that we know about for T or hormones. What about for people living with HIV that might be taking ARVs or whatnot? Is there any interactions that we need to be cognizant of?
No, it's not. So the vaccine is safe for people who are immunocompromised as well. So even if you are living with HIV and have a low CD4 count, the vaccine is safe. And the reason I say that is that the previous vaccine would have been a problem, but this new third generation vaccine is what we call a non-replication competent vaccine. So it is a live virus, but it can't replicate itself and cause infection in itself, whereas the previous vaccine could. So it's safe to have it. The only caveat to that statement is that if someone's living with HIV and they have a low CD4 count, they're less likely to produce an adequate response to the vaccine. So they may not be as protected from monkeypox as a result of the vaccine. And I think that's a really important question. And it's one that we haven't yet answered as a health community. What do we offer those people? And this is not something I have an answer to right now, but I imagine that that will be given a lot more thought over coming months as to whether those people would be assisted with additional booster doses or not. But that's not actually a conversation that's happening at the moment.
Okay, thank you. I think that's going to give people some clarity and also some confidence. Valerie, I do want to come to you, particularly around the eligibility. So particularly around what we saw with the first rollout of the vaccine. I'm wondering whether you can explain the different rollouts that we have in New South Wales, just so that people are really clear on what's available and when.
Yes. So as many people are aware, that we were able to secure 5,500 doses of vaccine in late July. And we were able to start giving that to very high priority groups, which included those individuals who would probably be more at risk of acquisition, but also severe illness should they get MPOX. And so that comes back to Vincent's point around people living with HIV who are known to be immunosuppressed were one of the priority groups. People who may have perhaps face homelessness, have drug and alcohol issues, and have obviously high possible exposure to others as well, and sex workers were in that group as well. But we also targeted people who were going to be travelling very shortly abroad to areas where monkeypox was known, and where people would be sort of facing this issue of being at dance parties or other areas. So that was the first tranche. That doesn't mean that's going to be exactly what we do in the next when we get the next vaccine, particularly now that we have local transmission. And certainly in the next tranche, we ultimately, at the moment, people are having one dose. The people who would be prioritized to have a second dose would be those who have low immune systems, who would probably need that second dose beyond, shorter time than others. That's one consideration. Again, that's under discussion, but that would be important. And then we would want to be vaccinating people who would be more likely to acquire MPOX locally, particularly people with high sexual partners and people attending sex on premises venues, and others who still might be traveling to those areas. But that hasn't been decided. We need to, that's, I can pretty much say that it will be along those lines, but really anyone who could be at risk, particularly at higher risk of monkeypox, will be prioritized.
So Valerie, we just heard Vincent say as well, and there's questions coming through on the Q&A chat around. So I think the first rollout of the vaccination was very much focused on gay and bisexual, queer, and men who have sex with men. what are the plans, or are there any plans to extend the current rollout for LGBTQ community members who might also be at risk? So I'm thinking about members of our bi plus cisgender women that may also be having sex with people in our communities. Will they also be eligible for the vaccine?
Yeah, I think it comes back to Vincent's point. You know, if you're having sex with a man who has sex with other men as well, regardless of your own sexuality or identity, I think it's really, really important, particularly, and we're looking at also within the community. I mean, while we're focusing on sexual contact, I think close skin-to-skin contact and household contacts becomes an issue as well. So I think we will be very much expanding those priority groups to make sure that people at risk of monkeypox are very much the target. And hopefully we'll have, you know, more and more doses to make sure that we're really well covered ahead of Pride.
Great, thank you, Valerie. That covers off some of the eligibility. Vincent, there's another question here in terms of if people have already had monkeypox, do they need to get a vaccine or vaccination?
Yeah, it's a really good question. I've thought about this a fair bit, and to be honest, I don't have a perfect answer for you. So theoretically, if someone's had monkeypox, mpox, they should be at least as immune as if they'd had a vaccine. And the reason I say that is that the mpox vaccine, so the Jynneos or the MVA-BN, different brand names, it consists of a virus that's been cultured that is very similar to the mpox virus. And we're just injecting it in your arm. Now, as you can imagine, if you have a full infection in your body and you've got, you know, lesions full of virus in your skin, that's going to induce a very strong immune response, and likely a much stronger immune response than getting a little jab of a related virus under your skin. So the point I'm trying to make is this hasn't been studied yet in terms of the antibody response that we would see to an mpox infection. And I know there are projects underway looking at this, so there are studies looking at this currently. But if I am to hypothesize, I would think that having an mpox infection induces a much stronger immune response than getting a vaccination with a related virus. So in other words, if you've had an mpox infection, I would assume that at least in the short term, but probably also in the long term, you have an immunity to getting reinfected. I'll be very interested to see what vaccine recommendations come out from, say, ATAGI around whether we provide further immunization doses to people who've already been infected.
Yeah, I would support that. And Vincent, I don't know if you've come across any, but I haven't heard of reinfections of monkeypox.
No, neither.
Yeah.
Okay, great.
So
yeah, can I ask? Oh, sorry.
No, go.
Can I ask you about, so international students or people that might be here on short or medium-term visas, what's needed in terms of Medicare access for the vaccination?
You don't need Medicare.
No Medicare.
No. So that was very clear. So we ran a large vaccine hub here in New South Wales, and it was available to anyone who needed the vaccine. And as Valerie said, there was specific eligibility criteria around your risk of MPX or monkeypox or mpox, whatever we're calling it. But whether or not you had a Medicare card was not an issue.
Okay.
So just to jump in on that, though, I do think a few lessons we've learned from COVID is that, say, international students or culturally and linguistically diverse communities, we really need to make sure that those communities are getting trusted resources and that we are actually doing messaging directly into those communities through community partners. Just because, like COVID, there was a lot of misinformation that happened around that time. And I do think, given that you don't need Medicare, which is great, that's going to be kind of, I guess, for all of us and everyone online, it's really important that when you are sharing information, especially across social media, you are sharing trusted sources. And hopefully we can drop some of those links in the chat for you. Yeah.
Great. I think that's a really good point in terms of there's often like information often flows in English first, but also what's available in languages other than English to give people some confidence and also some knowledge both about MPOX, the vaccination rollout. And that's really critical from a health equity point of view in terms of people having, it's one thing to say that it's open for people regardless of their Medicare status, but it's also about them knowing that they can get it and having the confidence and wanting to come through and get it and volunteering themselves. Okay, that's really, thank you very much for that. So I want to kind of now just do a little pivot to, let's say, look, we've started to see some local cases here of transmission, both in New South Wales and also in Victoria. Let's say someone has had symptoms or has symptoms. What should they do in the first instance? Valerie, if I can possibly come to you, and then
I mean, definitely you want to know to get a diagnosis. It may or may not be MPOX. You know, it can, and Vincent's probably better there as a clinician, but, you know, the most important thing is to go to where you would go to get a sexual health screen and get, so whether that's your GP or sexual health clinic. If you want to call the Shield line in the first place to get a bit more advice, that's, you know, that's also feasible. And sometimes, you know, pre-warning that you're coming in is also a good idea, but I'll defer to Vincent as what you would think would be the best approach.
No, I totally agree, Valerie. I just wanted, while I think of it, sorry, I just wanted to point out that, you know, I've described some of the symptoms of MPOX, but one symptom I forgot to include was proctitis. And I think this is really important because we've had a few people with MPOX whose only presenting symptom was anal pain or anal bleeding and no skin lesions. And of course that can be very confusing for people because that's, you know, if your butt is sore and it's bleeding, you might not be thinking about MPOX, but just keep that in mind, that is a possible presentation as well. But yeah, I completely agree with what Valerie just said. I think it's really important to urgently get medical attention so that you can get some certainty around whether or not this is MPOX, and if it's not MPOX, what it is, so that you can then get treatment for whatever else it is. And of course, what we've seen commonly is that people have, rather than have had MPOX, they've had syphilis or herpes. Those have probably been the most common infections that we've seen, sort of that are quite, for anyone, can be quite difficult to tell apart from an MPOX infection. And if it is MPOX, then the next step is to think about who you may have been in contact with. So after you've, you know, we're talking about you've been to the clinic, you've had the diagnosis of MPOX. Really important then to think about who you've been in contact with and which of your sexual partners might need to be contacted. And I think this is a really important point. Like, I think one of the things we should think about as a community, sorry, I'm just counting myself, I'm also a gay man, so I'm also part of the community. One of the things we should think about as a community is that is collecting contact details for people with whom you have hookups. And I know that's not always done. Like, of course, with apps like Grindr, if someone blocks you, then, you know, there's no way of contacting them around notifying them of a sexually transmitted infection. But I think as a community, we should think about, you know, if we're going to try and keep this contained, which so far we have, like so far, Australia has done remarkably well in containing MPOX transmission. But then to keep that ball rolling, as in to keep that contained, I think it's really important to keep contact details so that if you are diagnosed with MPOX, you can contact people and they can go and get tested and they can be aware that they've been exposed. And one of the important things about being aware that you've been exposed is then thinking about, you know, okay, do I now for, say, 2 weeks need to stop having sex? Because in that 2-week period, there is a risk of transmitting to other sexual contacts. So I think those things all come into play. And I think it's really important that as a community, we think about this in terms of making sure that we keep each other safe.
I just want to bring in Tim here, particularly around having conversations. And so we've just talked about close contacts, and, you know, there may be situations where people are going to have to notify either casual hookups or regular partners. Tim, how can we have conversations with our sexual partners about this?
Yeah, so one thing I really want to start with is that we don't shame or blame people when we do have those conversations. So we know through our history of HIV that when we do that, it actually discourages conversations and can lead to us people not actually going and getting tested and then actually spreading whatever the virus is. So again, don't blame and shame. That's one. The other one is that there's many services around contact tracing, which is really helpful. So I know that with New South Wales Health, there's also going to be support around contact tracing and that. But generally, it's the same sort of conversations we have around STIs. It's just having a frank conversation that, you know, someone you have had sex with might be at risk if you have acquired MPOX in this case, and that you recommend they go get tested and follow all the protocols that we put up around that.
It's never an easy conversation to have with your partners, particularly if it's not somebody that you might have met casually or, you know, on a few, but it is an important conversation. And Valerie, I'm not sure if you want to add anything in terms of the contact tracing that happens from New South Wales.
I think it is, I mean, a good idea to keep the contacts of your contacts in some form or other. And just to say, it's up to 3 weeks incubation period. We haven't talked about that. So that could be quite a lot, you know, what did I do 3 weeks ago? And try to remember that. So I think it does help if you sort of have a way of noting that. I know that because we probably, you know, will start to engage with the sex on premises venues and how they may want to also, you know, introduce some way of partners knowing who's come through the, you know, if there's been an outbreak within a sex on premises, how do we contact people? And they may sort of want to start having that conversation around how we keep, you know, be able to contact people who'd sort of gone to some premises. But it is up to 3 weeks. So, you know, I can't always remember what I've done. So, you know, it is worthwhile thinking that. And I totally agree. It's not, you know, we all have sex. Transmitted infections have been around forever. So it's not about, you know, who did what to who. It's just, you know, making sure we get on top of it, really.
Tim, can I come to you in terms of what's ACON doing with, I think during HIV and even the early days of HIV, there was a big call to have venues closed. Sex on premises venues in particular. Is that the case here? And what is ACON doing with venues if that's not the case?
Yeah, so that's not the case. I love the leading question from the other ACON member on the panel. But with that, just to flag that ACON's been doing a lot of work with sex on premises venues and actually keeping them up to date. But talking about what Valerie and Vincent said, it's also reintroducing check-ins. So for us, that's really important because it means there's a contact list that the SOPV has access to, and then we as ACON, who works with SOPVs, can actually contact everyone who has actually been through that during the period. That's most of what we've done, isn't it, Matt?
Yeah, I mean, that's the key one, as well as to sort of say that venues also play a really key role in getting information out to members of our communities. And that much more than sex, I think venues also play a role in a community meeting place for a lot of people that, you know, may not be connecting in with other aspects of our community. So there's lots of venues that are around that cater for a full spectrum of people. And by having these venues and getting messages from ACON and New South Wales Health into those venues and potentially looking at options for, you know, promoting vaccination or encouraging vaccination is also really critical. And, you know, simple things like making sure that you ask to do a COVID check-in when you're entering is a key thing that means that you can be followed up if there's anything that needs to happen. I think it's been really critical that the venues have played such a strong role both through our experiences with HIV, and they remain a kind of key partner in that education that we do with community.
And I guess just to reinforce on sex on premise, before I went to the UK, I worked in Sydney, and I was part of the team that went to all sex on premises venues around the Shigella outbreak that we had 20 years ago, and that's where we, built an extraordinary relationship. And the work that's been done is known abroad as being extremely avant-garde in that we have that really good relationship where we can get messaging out, but also very good participation from venues. So of course we wouldn't close down venues. It's about the communication and being able to very quickly get on top of it. You're on mute, Matt.
I knew that was definitely going to happen tonight.
There's been
Valerie,
one mute. It wasn't me.
It wasn't me. So there's been a couple of questions that have come out in response to the rollout, and so the initial vaccine, some of which we've covered. But I just want to kind of go through and touch on some of the we've already, I suppose, touched on who will be considered high risk or prioritized in terms of the vaccination. And I think that's been really fantastic. We've heard as well that there's the opening. So in terms of it's not so much about how you identify, but who you're having sex with is going to be a key part of whether people should read themselves into the vaccination rollout and ensuring they're going to be eligible. Valerie, what work will need to be done, both, I suppose, Tim, from ACON's point of view, but also New South Wales Health, to ensure things like a smooth process in terms of the registration form and also coming into the clinic is going to be open and accessible for communities that may not be part of the traditional gay or the first rollout vaccine with gay and bisexual men?
Yeah, so I mean, just to say, in record time, we were able to establish the Crown Street Centre for this purpose, and I think ran extremely smoothly. And I really want to thank the local services and the community for their engagement in this. It has been terrific. I'm sure Vincent can chime in with that. And to bring, first of all, a workforce very, very quickly, including the nurses and the educators and the doctors and everybody to set that up, and making sure the messaging in there to get the process of priority to book. All of that's been really, really quick, and it hasn't been perfect, but given what we've had and the time that we've had it, I think it's really worked extremely well. So we want to learn from that with the upcoming vaccine. We want to make sure we can, as I said, potentially multiply doses from subcutaneous to intradermal if it's feasible, but that actually entails a lot more training. Not every nurse is capable of doing that because it is a special technique. So there's some resources implications, and there's also making sure the vaccine is now available outside the Sydney area a lot more widely. It has gone out to sexual health clinics, but in smaller numbers. We need to make sure that many more people from the community, from wherever they are across New South Wales, can get to a vaccine fairly quickly if they're at risk.
Right. So I guess just to jump in on here, it's also about actually starting to tailor our approaches to the kind of communities within the community that we're talking about at large. So we have taken a kind of broad approach, which has been fantastic. But now we're really going to have to start looking at, say, First Nations communities and how we need to actually do tailored messaging for these communities, which, as we saw with COVID, there was hesitancy around vaccine uptake, and what we can do in terms of communication and working with community around that. Another one I would add, which I've said earlier, but I'll bang on about it, is culturally and linguistically diverse communities, and again, tailoring messaging for these communities. In terms of the actual response, one of I think the excellent outcomes of the clinic is that ACON can actually have community members greeting people at the vaccine centre, and that really helps kind of establish that relationship with community. So actually having, communities from First Nations, they're culturally and linguistically diverse. So for instance, I think we did a trans and gender diverse clinic and that filled up within 2 hours. So when we do targeted and tailored messaging, it works really well. So on my end, that is what we'll need to focus on as we now continue the rollout when we get more supply.
Great, thanks, Tim. So we've got about 15 minutes left, and I'm aware that there's a lot of questions that are kind of unanswered, and we're trying to get through as many as possible. Vincent, I want to come to you for a bit of a lightning round. This one's going to be fast and furious.
It's going to be a shotgun Q&A session.
Because a lot of the questions are particularly medical based. Sure. And one of the ones that came in, can you get symptoms like respiratory issues, pain or discomfort and not others?
Short answer is yes, you can get some symptoms and not others. So not everyone gets all the symptoms. I just want to point out it's not respiratory issues. So respiratory symptoms are not generally part of MPX or MPOX. So it's just to run through them, because I think it's really important that people know the symptoms. So it's fevers, headaches, muscle pain, joint pain, back pain, and swollen lymph nodes, and they tend to cluster together. You might not get all of them, but they sort of tend to happen at the same time. And then separate to that, you've got the skin lesions, which can be blisters, ulcers, scabs, little lumps. The skin lesions tend to be very painful. And with that, you can also get anal pain and anal bleeding. But as I said earlier, sometimes you only get anal pain and anal bleeding and no visible skin lesions. That's very short.
Any of those kind of symptoms, please do reach out to your sexual health clinic or call the New South Wales Sexual Health Info line. One of the team can put those details in the chat, but I do want to move through to the next kind of question. Vincent or Valerie, how long does monkeypox live through in bedding or clothes, etc., unwashed laundry?
So to put it succinctly, so as I said, monkeypox is related to smallpox. Smallpox can survive in a tissue matrix, which I'll explain what that is. Can it survive in a tissue matrix for decades? And a tissue matrix would be something like a scab that you've picked off a lesion, right? So keep that on one side. Now, on the other side, it's really easy to kill monkeypox. So if you expose monkeypox virus to ultraviolet light by going out into, hanging your bed sheets in the sunshine, or to detergent, it's quite easily killed. So I don't think transmission through bedding, that's something we call fomite transmission. I don't think that is likely to be a significant issue in this outbreak. And the reason I say that is, again, if bedding transmission and transmission on toilet seats was a significant issue, we would have seen mpox or monkeypox everywhere. Everyone would have got it, and that's not what we're seeing. We're seeing sexual transmission.
Okay.
So can I just translate for community? That means keep up good hygiene practices, wash your bedding, just to really translate, and don't hold on to those scabs.
Yeah, no scab collections, please.
No scab collections, very key. Okay, Vincent, sorry, another couple of medical questions here. So you mentioned that there was evidence to suggest that monkeypox could stay in ejaculate for quite a long period. What do we know about it in terms of vaginal fluid, front hole fluids, or things like pre-cum as well?
Sure. So the reason semen or ejaculate is likely to harbor MPX or monkeypox for a long period of time is because the testicles need to be shielded from the immune system. So the testicles contain your semen, and semen is a little bit different from the other cells in your body in that the DNA is a little bit different. And so it needs to be walled off and separated from the immune system. Otherwise, your immune system would start killing off your semen. So because of that, if you get monkeypox in your testicles, it's likely to be able to hide away there for a long time because the immune system can't get to it. And that's why we think that mpox hangs around in semen for a long time, and that's why we advise people around the risk of semen after someone's recovered from mpox. That same logic does not apply to vaginal fluids or pre-cum.
Right.
Can I just ask though, so if semen comes into contact with someone's skin, are you likely to get monkeypox?
So monkeypox doesn't appear to be able to transmit it, doesn't look like it transmits through intact skin. If someone comes on a cut in your hand, then that might be an issue.
Right. Okay, but I suppose it is important to kind of say, like we said at the very beginning, this is based on what we know currently now, and that some of this information may need to be updated as we start to learn more, and that ACON will do its best, or to provide updates to all of this information as we start to learn more. And I think the best way to do that will be through the ACON website, which one of our lovely team members will put in the chat as a where to go for more information in terms of the FAQs. We've got about 7 minutes left, and I want to continue on through the lightning round. We've already talked about breakthrough cases.
Sorry, can I just, Matt, can I just clarify with my semen answer? So I'm not saying that Mpox can't be in vaginal fluids and pre-cum, but I was saying that after someone's recovered from Mpox, and we were still worried about ongoing risk from transmission through semen for that 8 to 12 weeks after they've recovered. We're not worried about vaginal fluids and pre-cum in that situation.
Right.
While someone has active Mpox and they're unwell, then certainly all bodily fluids can potentially carry Mpox.
I think that might be a potential question that we're going to need to write out an answer for, and we're going to have that moved onto the ACON website, hopefully within the next couple of days. So I'm going to come back to you and you can help clarify your response to that for people, because it's going to be key. A quick one here in terms of if people were vaccinated for smallpox many years ago, will they need to get vaccinated for Mpox again?
So yeah, the short answer is yes, it is recommended that people who were vaccinated many years ago, and for most people that would have been before 1980, if they were living in Australia, or if they were living overseas, they might have had it more recently. They would have had a single dose of the ACAM 2000, most likely, the one that Valerie mentioned. It would still be recommended that if they are at risk of Mpox, that they get vaccinated, but they will only need a single dose. They won't need a double dose. So they won't need 2 doses 28 days apart.
Okay, great. What about Valerie or Vincent, in terms of people who are under the age of 18 and maybe needing to access monkeypox, Mpox vaccine? Is it available to under 18s? That one we might have to take on notice and come back to
take on notice. I don't think there's any problem. I can't remember. Sorry, Valerie. I can't remember what the age cutoff is. The lower.
Yeah, so it's 16.
Yeah.
At the moment. That's the ATAGI advice. So under 16, it's not recommended to have the vaccine. 16 to 18 is a bit of a grey area, but certainly over 18, it's more of an adult. So I think the ATAGI is consideration on a case-by-case basis for those 16 to 18.
Great. Another question here: is there treatment available for monkeypox?
Very good question.
Mpox, sorry.
Yeah, for Mpox, there is an antiviral. Its official name is tecovirimat. And if you don't want to participate in word games, TPOX is its short name. It is available. However, again, there's an issue with supply. So there's a limited supply available. So we're reserving its use for people who are either experiencing severe symptoms of monkeypox, or for people who are at risk of severe monkeypox. So particularly people living with HIV who have a low CD4 count may need to commence on TPOX. But for everyone else, so again, to highlight, because I don't want to, I think it's important tonight that people don't come away from this alarmed. I think, again, it's one of those scenarios where it's important to be alert, but not alarmed. For most people who get Mpox, they're likely to experience an illness that is of a limited duration. So generally 3 to 4 weeks, usually 3 weeks, sometimes 4 weeks, and it resolves by itself without any need for specific antivirals. They may need antibiotics if they get secondary infections on their lesions, and they may need painkillers. So I'm not saying that people don't need treatment as such, but they may not, they're very unlikely to need antiviral treatment.
Excellent. So we've got about 4.5 minutes left, and I just want to give an opportunity for you to give some closing remarks. I also want to say that this won't be the last community forum that ACON's going to do on monkeypox. I think if tonight showed us anything, that there is a lot of information here that needs to be covered. And there's a lot to try and unpack in terms of what we know, what we don't know. And I think that information is only going to become more and more critical as we get to the next stages of the vaccination rollout. So we, in New South Wales, I think, Valerie, I'm not sure if you mentioned it earlier or whether I just know this from other sources, we are expecting a second round of vaccinations to come in when?
So late September to early October, we should get an allocation for New South Wales at around 25,000 is what we're looking at this stage, but that could change. Hopefully, we will also get additional vaccines in the early part of next year. So, those 25,000, if they multiply by 5,000, that's over 100,000 single doses for individuals, so that we would be in a very good place if we can do that before World Pride. One thing I would plug in is that because there's so much we're trying to understand, we will be inviting people to fill in a few more forms perhaps to ensure that they complete after vaccination, get on the air, and then they'll potentially receive surveys to make sure that we record any side effects. We may enroll people into studies to see whether there are breakthrough study of vaccines. All of those will be really, really important. So if you do get asked to participate, please think about participating so that we'll all increase our knowledge, particularly in the context of Australia.
I think that's a really kind of good almost closing note. There, like as we've kind of said, there's a lot that we don't know. And I think there's been a huge response in terms of research from people in our communities. And so that's having that evidence base is going to be a really key part. And so if you are asked to participate in a survey or any kind of follow-up, that's going to provide critical information that can be used for both future rollouts here in Australia, but also provide a lot of insights around the world. And that might be another question that we also, because I know a couple came through in the pre-questionnaires around evidence base and what we're doing in terms of collecting information. So we might put that in terms of a frequently asked question. Tim?
Yeah, so just to finish off really quickly, 2 main points. 1, we need more and more tailored approaches. 2, we haven't mentioned like really simple strategies to ensure people read themselves into this is things like saying the gay, bi or bi plus and queer community rather than just the gay community. Like they're really simple ways to ensure that everyone we're targeting actually reads themselves in. So that's what I'll finish on. Really simple strategy.
And, we, always take on board messaging that we hear from community in terms of feedback, whether that's on forms, whether that's on the way that promotion exists. And often that feedback is also being relayed and very receptively heard from the ministry. There was a limitation on what we could do with the first round of rollout, but it is something that we're looking to improve in terms of both those forms that are filling out and also the promotion that we do. Vincent, any closing remarks from yourself?
Yeah, look, I think I just wanted to address that, I'm aware that there's been a lot of anxiety and worry around MPOX in the community. I would just like to reassure people that there's a massive amount of effort going on behind the scenes to address this properly. And I'm not speaking here as a government representative, but I would like to point out that the various levels of government in Australia have been very proactive in responding to this. So I just want to kind of reassure people that everything is being done to address this properly. And the only other thing I would say is that I think the community has played an amazing part in the response, and I would just encourage people to stay connected, keep talking to each other. And as more information comes out, it'll just be important to stay on top of things. So Matt, I'd say another forum would be a great idea.
Another forum, and it may even form part of a series. If I can thank all of our speakers for tonight, so Dr. Vincent Cornelis, Dr. Valerie Palesh, and Timothy Walk, thank you very much for sharing your wisdom and experience with our community. It really is critical to both their knowledge and their day-to-day as we start to engage with monkeypox. To all the people that have attended the forum, thank you. If you submitted a question, we really do appreciate it. We'll keep a record of these questions and we'll add them to the lists of future forums. And we'll also look at some of the themes that we might need to pull out and add those questions and responses to our monkeypox website, our MPOX website, which is available at aconhealth.org.au/monkeypox. A big thank you to you all for coming and good evening.